Okay, hello everyone. Thank you for inviting me today to talk to you about the endocrine manifestations in adult Chester disease and our experience here. Endocrine manifestations in ECD were only described in a few case reports, so we decided to evaluate the prevalence and evolution of endocrine manifestations in a large cohort of patients that are followed here. So it's an observational monocentric study. We took patients with confirmed Erdheim Chester disease, followed here in Professor Armoir's department, and who were addressed in our endocrinological department here in Testicular Hospital. And I present here the consecutive patients that we studied between October 2007 and May 13. All the evaluations were done during hospitalization. Evaluation criteria were on ECD, the diagnosis, the evolution, localization, treatments, and the endocrine evaluation was clinically we looked at the BMI, BP, we looked for diabetes insipidus, sexual dysfunction, we examined the genitals, breast, thyroid. We evaluated metabolism and, of course, hormonal functions, anterior and posterior pituitary function, peripheral gland functions, the gonads, the adrenals, the thyroid and parathyroid. And we performed several imageries like pituitary MRI, pelvic or testicular sonography, adrenal CT, which were usually done in internal medicine, and bone densitometry and thyroid sonography. And for some men, we could perform sperm counts. So our experience was recently published. The patients were mostly men. So 15 male and 14 female. Mean age at diagnosis was 54 years, and age at first clinical signs of ECD was around 50 years, so time before diagnosis was around 5 years. Age at first endocrinological symptoms was around 44.8 years, and age at first evaluation here was 57.6. We could see inaugural endocrinological manifestations in 23% of the patients, and mostly it was diabetes insipidus. When we first evaluated the patient, there was a non-endocrinological involvement in 36% of the patients, and mostly diabetes insipidus. Here are all the endocrine manifestations we found in order of frequency, and you can see that the most frequent deficit is growth hormone deficiency, which is really, really frequent, almost 80% of the patients. Then, and I'll talk about it later, the testicular deficiency, which is found in more than a half of the male patients. Hyperprolactinemia is very frequent, but it's very mild and never needs to be treated. Diabetes insipidus, as found in previous studies, is found in a third of the patients. Gonadotropic deficiency in male and female is about 20%, and then there are almost 10% of patients with thyrotropic deficiency, same number with thyroid deficiency, and corticotropic deficiency is pretty rare, and adrenal deficiency was found in only one patient. There is one patient in the cohort who doesn't have hormonal dysfunction, but this male is one of the youngest in the cohort, and he has infiltration of the pituitary on MRI, adrenal infiltration on CT, and testicular infiltration on testicular sonography. So maybe he'll have an hormonal dysfunction later. Pituitary and or stalk infiltration is found in 24% of the patients, and so it's important here to note that a normal pituitary MRI doesn't rule out pituitary dysfunction, hormonal dysfunction. Absence of the posterior pituitary bright spot is found in 60% of the patients. It's not correlated to diabetes insipidus, and it never is. Adrenal infiltration is very common. 39% of the patients have this famous adrenal infiltration here, and it's bilateral in 2/3 of the cases, but still the hormonal disturbances of the adrenal is very rare. Here you see a stalk enlargement on MRI. There is no correlation between anterior and posterior pituitary deficits, no gender difference apart from gonadal insufficiency, which was not found in women, but then we only have 14 women and most of them are menopausal. Anterior pituitary deficits, here that I've shown you, appear in the same order of frequency as seen in Langerhans cell histiocytosis or after radiotherapy. About the anterior pituitary deficit, I just wanted to show you how common they were and to show you that you really have to look for them. Here you can see that at least 70% of the patients have 70% of the patients have at least one deficit, and only 5% have no anterior pituitary dysfunction. And here, people who are here have no dysfunction, but then the explorations were incomplete. 55% of the patients had at least two deficits. And when you look only at patients with complete explorations, 91% of them have at least one anterior pituitary deficit. So it's like almost everyone. And at least two deficits in 70% of the cases. So it's really, really frequent in ECD. The other important message for me here is the frequency of the testicular deficiency. We weren't expecting that number, and so you see that more than 50% of the male patients have testicular deficiency with a small testicular volume, and very frequently infiltration on sonography in almost 30% of cases. We could perform sperm counts in only 6 patients, and they were really altered in 5 patients. However, there is a small number of patients, and we didn't find any correlation between gonadotropic, gonadal function, sperm count, and testicular use findings. However, we found a very strong correlation between testicular volume and the gonadic function, which is not surprising. On sonography, testicular infiltration is usually bilateral. It's hypoechoic pseudonodular with a low vascularization. It could look like tumor, but it's like in adrenal rest tumors. The context, the fact that it's bilateral, pleads for the fact that it's infiltration. And in fact, one of our patients could have a testicular biopsy of one of these images, and the biopsy confirmed that it was really Erdheim-Chester disease infiltration in his testicles. I will finish with the recommendation. Maybe I'm not going to read all this, but the message is that I think it's very important that all patients with Erdheim-Chester disease have an endocrinological evaluation and are followed regularly by an endocrinologist, because the deficits are so common and they need to be treated, and they can appear progressively during the evolution of Erdheim-Chester disease. On the other hand, usually deficits, when they are here, they don't disappear. Diabetes insipidus, corticotropic deficiency, GHD, never disappear in our experience when you follow the patients. So you have to check on them pretty regularly. You have to look for signs of anterior or posterior pituitary deficit, perform pituitary MRI, and of course, the endocrinological tests with dynamic tests. Look for gonad involvement, and in men, I think that men who are young and who still have parental project should absolutely have sperm cryopreservation when they have Erdheim-Chester disease. So that's an important message, I think. And so look for thyroid involvement. I didn't talk a lot about it, but it exists. And adrenal, breast, it has been also shown in the literature, and we have a patient we think has has breast infiltration. And metabolism, I didn't talk about it, but they have very high cardiovascular risk because of Erdheim-Chester disease, but also because they are more often overweight than general population, more often hypertensive, like 50% of them are hypertensive, and almost 30% of the patients have diabetes, and it's not correlated with corticosteroid therapy. And it's 7 times more frequent than general population. So I really think that those patients should be considered with very high cardiovascular risk. And also the pituitary deficits and the substitutions increase this risk. Okay, so I want to thank Stéphanie Logier, who helped me to do this work, Philippe Touraine, my boss, and of course Julien. Julien Roche, Fleur Cohen, Zahir Hamoura, and thank you for your attention.
Any questions from?
In children who are growth hormone deficient, they sometimes manifest problems of energy and strength. Do you see that in adults, as you saw so many people with growth hormone deficiency?
Yes, but it's very non-specific. All those signs are really non-specific. So yes, growth hormone deficiency in adults can they can have signs like fatigue, low muscular strength, but all of those are not specific. And I have only one patient with Erdheim-Chester disease whom I treated with GH, and I don't know yet whether it's going to be efficient or not.
I have a question about the metabolic complications, especially diabetes. So did you further characterize if it's more a phenotype of the type 1 diabetes, diabetic patients, insulin levels, or more insulin resistance towards type 2? And since also both kinds of diabetes are now inflammatory diseases as well, do you see any benefit of the treatment on this?
Yeah, it's a very interesting question, and we thought about that, but it's true that when we did that study, we didn't think about diabetes, so we didn't characterize the diabetes, so we don't have that answer. We didn't look at the pancreas either. We should look whether it's infiltrated or not, so we didn't phenotype the diabetes, but I think it's a very important feature as it's so frequent, and that was not expected. So yeah, it's very interesting.
When it comes to testicular infiltration, I mean, do you see it on the PET scan as well, or do you have to do just specifically ultrasound for that purpose?
Okay, this is a very good question too, because PET scan is it's like one of the most important exams for you in Erdheim-Chester disease, and it's very bad for endocrinological involvements. It's very bad for the pituitary, it's very bad for the testicles. It's pretty bad for the adrenals too. So no, you can have patients with infiltration and sonography and no image and PET scan, and the opposite was seen too in one patient. So no, it's not a good exam. Most of the patients who have infiltration, testicular infiltration and sonography, don't have anything on PET scan.
When you spoke about low level of testosterone, did you correct it to the age of the patient?
No, we didn't. We have the same norms for everyone, but of course, it was really below the lower normal range. We consider that there is low testosterone when it's really, really under the lower range.
And do you treat these patients?
And do I treat them? Yes, I do, yeah. I do, and usually they feel better. They get more strength, they're less tired, and they get back their libido and erections, so usually they're pretty satisfied, yeah.
So what's the indication of giving growth hormone to the patient you treated?
Well, growth hormone in adults the indication is on fatigue a little bit, but it's mostly on body composition, muscular and fat mass, and on osteoporosis, and on the different cardiovascular risk factors. And when patients are substituted with all the other hormones and are still very tired and have really severe GHD, usually we try to treat them to see whether they're better or not. So I mean, GH is, there's no discussion about GH in childhood and even in young adulthood until 25 years. After, it's true that it's a discussion, it's not a vital hormone, and usually when we try it, it's because people are so tired. We hope they'll have a better quality of life if they're treated.
Thanks very much. Oh, you have one last question.
One thing that we haven't discussed at this meeting, I don't know if there's any data about it, is the rehabilitation of patients that have some deficits. What happens when they subject themselves to physical therapy and rehabilitation. And one of the things I've encountered is the issue of fatigue. And I never thought much about replacing testosterone growth hormone, but what I see is the patients that do well, usually they have some sequelae, they get better with therapy, and then they plateau. Now they keep complaining of fatigue. So I wonder whether optimal endocrine management can have an impact on the potential to rehabilitate and become more functional.
Sure it does.
Well, I think so too, but we haven't spoken about that because we probably don't know.
Yeah, I'm sure it does. I mean, ECD is a very tiring disease. The treatments are very tiring. Most of the patients are in poor general state health, and they can gain a little bit of quality of life and maybe life expectancy, and well, at least feel better with those hormonal substitutions. I'm sure it's important to do it.
So maybe next year we can have somebody from physiatry or somebody give a little summary of what the experience has been there, because it's an important topic.
Yeah, definitely. So we move on to the panel. Thank you very much.
Thank you.
Carine.